My specialty is physiatry, physical medicine rehabilitation. So if you have not heard of that before, it's in essence non-surgical musculoskeletal medicine, non-surgical orthopedic medicine in essence. I'm not a psychiatrist. I'm not a physical therapist. I am an MD. It's a good specialty to be in because about 85% of all musculoskeletal injuries, be it spine or sports injuries, can be treated conservatively without surgery. Okay, and so it's kind of a little bit of a bad social pattern we've gotten into that the second something hurts, you want to go to the orthopedic surgeon. That's really not the first stop. You want to find out what's going on, and only 15% of the time will it actually result in a surgical intervention. So that's where I come in. And it has to do with acute or chronic injuries. I do not discriminate. So Winston Churchill said, "Pain in the human body calls attention to an unhealthy state of things." That is very, very true. It is a protective mechanism that we have that is supposed to keep us out of trouble. But at some points in our life, pain just becomes an annoyance because we will slowly have some degenerative types of things go on and they will become painful. But that pain is now no longer a protective mechanism. It is just a debilitating mechanism. And so we just need to take care of it. Also, Julius Caesar said, "It is easier to find men who will volunteer to die than to endure pain patiently." So anybody that's been in pain for any significant length of time can certainly relate to that. You get desperate. You start thinking that things are falling apart, and you start thinking that the way of life is going to change tremendously because it's an all-encompassing type of event. So I'm going to go over just a few common conditions that many of you have probably heard of or had. Bursitis, tendonitis, arthritis, osteoporosis. These are very broad categories, and bursitis, tendonitis, and arthritis are many times, they run hand in hand. You can see them in all parts of the body, and I'll go into a couple of details, but then osteoporosis is a bit of a standalone that is a very important one for women. So bursitis, the bursa is just a fluid-filled sac that goes between a tendon and a bone and helps with the gliding of that tendon over the bony prominence. So a very easy example of that is the trochanteric bursa, which is shown right up here. And what happens is that's right here on the hip. So truly kind of outside hip pain. That can come from walking, jogging, an elliptical trainer. It can come from if you've laid on something hard for a period of time. Once it gets inflamed, it's kind of hard to get rid of. And you start thinking that it's more than what it is because it'll wake you up at night, it'll be burning, it'll be radiating down the leg. You start thinking you have something more wrong with you than what you actually do. So really all it takes is a bit of a mindful kind of approach to parse out all the other pieces and parts and really focus on where it's coming from. Another thing is subacromial bursitis. It's up in the shoulder, usually just painful when you move your arm. Once again, can wake you up at night. Olecranon bursitis, right here on the elbow, can get swollen up, even from just having your elbow on a hard surface for an extended period of time. And then pes anserina bursitis, a big $10 word that I had to go to school a long time to learn. But that's right here. And I've had so many people come in that say, "Oh, I think I need a knee replacement. It's just, my knee's falling apart," and they haven't even had an x-ray. They haven't seen anybody about it. And really, it's just a bursitis. And these things are so simple sometimes, but they just have to be targeted appropriately. Tennis elbow, tendonitis, golfer's elbow, Achilles tendonitis, plantar fasciitis, de Quervain's tenosynovitis, which is just another $10 word, that right here on the wrist, that oftentimes anything you're doing things repetitively with your hands, you can get inflammation. And then even trigger fingers, that is a type of tendonitis. And it's basically where the tendon swells up and it goes through these ligamentous pulleys and it'll get stuck and then release. And so it's a type of tendonitis that can cause a bit of dysfunction. But once again, each one of these things, these terms you may or may not have heard of, but the pain that these things can generate is excruciating and debilitating. Tennis elbow or golfer's elbow, even when you turn the key in your car, it feels like a knife going right into your elbow. And once again, I'll state, it makes you think that there's something more there than what there actually is. So once again, it's important to just take a couple steps back and don't get overzealous about trying to go for something big as far as treatment. Degenerative joint disease. Arthritis is a bit of a misnomer. It's a word that is thrown around quite often anytime we see a joint that is degenerating and has maybe some bone spurs or breakdown of cartilage. Degenerative joint disease is also a misnomer. It's not really a disease state. It is just a normal age-related process. So if we were to take MRIs of 100 people in their 30s to 40s, 70% of them would have a disc bulge or a disc herniation, but be completely asymptomatic, no pain whatsoever. So what does that tell you? Well, radiologic studies are only worth how they relate to what your symptoms are. So many times we will see incidental findings like hip arthritis, knee arthritis, bulging discs, things like that, and it's actually not the true source of where your pain is. So once again, a mindful approach to listening to when it hurts, how it hurts, where it hurts, then coupling those things together with these radiologic images, that's what makes the difference, because arthritis, it's everywhere. We're all going to get it. It starts in the third decade of life, fourth decade of life. So when you hear somebody say, oh, do I have arthritis? Well, of course. Of course you do. We all do. But whether or not it's a painful entity, that's the big differentiating factor. Chondromalacia patella. Anybody ever heard of that one? All right. Once again, it sounds a lot worse than it is. It's just a little bit of breakdown of the cartilage on the back of the kneecap. But the aching nature of pain that you get when you're in a seated position, it's called a theater sign, actually, because if you're sitting in a seat for more than about an hour, the knee just starts to ache and you need to straighten it out. And oftentimes when you straighten it out, it pops. Going up or down stairs, it starts to hurt. Once again, this is not a type of diagnosis that necessitates something like a knee replacement. And oftentimes people will come in and it'll just be chondromalacia patella, but they already have it in their mind that they need a knee replacement. So it's just getting the right diagnosis first. So back pain, I mentioned earlier that if you do that MRI, 70% of non-painful people will have a disc herniation or disc degeneration. 80% of the population will experience back pain at some point in their life. 80%. That's a massive number. Now, that's not to say that 80% have it all the time. It's just, it'll be an episode. And the thing that's interesting is we see disc degeneration start to occur in about the third decade of life. So that's where we start to see a black disc, mildly degenerated, a little bit bulging. Those are terms that when people read an MRI report, that's one of the most dangerous things you can do, by the way, is read your own MRI report. Because there's dozens of things that the radiologist will comment on, and that's his job, his or her job, is to pick up all the details of whatever is in that image, that standalone image. But he hasn't examined you, he hasn't really talked to you, he doesn't really know where your symptoms are coming from. And so when I look at it, I'm looking for about one or two things. I see all the stuff that he saw, but I'm really trying to focus down onto what is relevant to your particular situation. And so the disc degeneration, as I said, can sometimes be an incidental finding. Now, it usually goes through an inflammatory type of process in the early stages, and that can be represented as having some back pain. But as time goes on, it'll be this cyclic pattern where you'll have some pain, you won't have some pain, you'll have some pain, you won't have some pain. That could go on for 5 years, 10 years, 15 years. Then one day it burns out. Why does it burn out? The reason it burns out is because it goes from this to this. There's a certain point in time when that shock absorbing cushion just gives. And then the bone starts to try to grow across and immobilize the painful area. So then that's called spondylosis. And once again, spondylosis is a big catch-all term for arthritis of the spine. It just means that you're getting some bone spur formation, the discs have degenerated. Now the other thing that can happen with the bone spur formation, spondylosis, is it can start to encroach on where the nerves are in the spinal canal or out in the neuroforamen. So that's when you can sometimes see some radiating pain down the legs as you stand and walk for certain periods of time. But once again, not the end of the world. Very manageable. This is what it all comes down to. Dehydration. In a disc specifically, this is one of the best analogies that I've ever been able to come up with because it's so representative of what is happening. This, if you take a grape and you just squish it a little bit, it's very resilient. It'll go right back to its form. If you finally push it beyond its limit, it will break open. It's exactly what a disc will do, given the right circumstances. Now then the raisin. The raisin is a completely dehydrated disc. It's already lost any of its resilience, so it just flattens out, kind of bulges out. So that's exactly what happens between these two images. This one being a healthy disc, this one being a spondylitic disc with some bone spur formation. So this is what the disc actually looks like under radiologic imaging. And so this is a discogram that I did, and this is a normal nucleus. And so what that means is the disc is made up of two separate components. You have an annulus, which is the outer thick ligamentous attachment, and then the nucleus pulposus, which is inside, and that's the squishy stuff that gives it this kind of shock absorption characteristic. Now, this little illustration over to the right-hand side kind of shows you what that really would look like if you took a cross-section. Now, this is a degenerative disc, all right? The annulus has started to bulge out. The nucleus is no longer nice and contained. It starts to squat out to the side. But here's what you can see. There's a little bit of a bulge, but you still have plenty of room in the neuroforamen. That's where the nerves exit. So you can have these types of things and have absolutely no pain going down your legs whatsoever. You can have these things and have no back pain whatsoever because it may have gone through its inflammatory phase. This is what an MRI of a same disc looks like, where you have a normal disc up here and an abnormal disc down here. And so the thing to note right out of the gates is this color. On an MRI, on this T2 weighted image, this is what it's called, when you see gray, that's usually gray or white is a sign of fluid, okay? So right back here, this is where the spinal cord is, and all this white is representative of the fluid that goes around the spinal cord. Now, the fact that this is gray, that means it has really good water content, so that's going to be a good, healthy disc, whereas this one's dark. And the dark disc, it's a very common finding. It's nothing to be afraid of, but if you were to hear a radiologist's description of this disc, you'd think your back was falling apart, right? So don't get excited about that. Now, this is something that is very applicable to our audience today, osteoporosis. About 54 million Americans have either osteoporosis or low bone density of some sort. And it's, you know, it's the silent threat that's out there. It comes on postmenopausal. It increases the risk. You get decreased bone density and bone fragility, and about 7,000 spinal fractures occur a year. That's compression fractures. And if you look at this over here, really what it just is, the density, you can see these little bridging kind of interwoven matrix that's in a normal vertebrae. What happens is you start to lose the density of those little matrix weaving together, and then you have more dead space in between. And as you can imagine, if you have less cross-linking, it's going to weaken the structure until such time that it finally fails. And unfortunately, you'll have no symptoms of osteoporosis by itself until something fails. The most common areas of fracture are in the spine, whether it be the thoracic spine or lumbar spine, and it's most commonly at the thoracolumbar junction, so that's right down at the bottom of the thorax or upper lumbar spine. And what will happen is once it fractures, you tend to kind of fall forward, and once you've had one, you're at risk for another one. Fractures occur in otherwise healthy individuals. Just kind of comes out of nowhere, and it's minimal trauma, sneezing, coughing, even sitting down hard. And the classic thing that I hear when people come in is, I wasn't doing anything. That's it. I wasn't doing anything, and all of a sudden the pain comes on, this intense stabbing pain in the back. And so this picture over on the side, once again, this is just the same concept just in the hip, all right? So this is the femoral head, and then here's the trochanter and down the femoral shaft. And so you'll see that this is a higher density kind of matrix than this over here. And once again, it's just physics. It just comes down to physics. When you start losing those cross links, it starts to become weaker. So osteoporosis, the non-modifiable risk factors, you can't change that you're female. You get decreased estrogen postmenopausal. Men start getting decreased testosterone. European and Asian ancestry increase the risk. There's other hereditary links. Early menopause and then a hysterectomy. If you had a hysterectomy at an early age, you're going to be at increased risk. Now, the modifiable types of risks, dietary, vitamin D, too much, well, smoking at all, excessive alcohol. So that means the 2 martini lunch is okay, but the 3 martini lunch, it's a little, that might push you over the edge. Has anybody already hit that mark today? So malnutrition, underweight, and then inactivity, but then also endurance training. So it's kind of the 2 opposite ends of that spectrum. So inactivity, you're not putting enough stress on the bone, so it will not go ahead and remodel the way it should and stay strong, so it starts to just go away. Endurance training, however, you see these women that are in great shape, or what would appear to be great shape, but when they deplete their fat stores, when their body fat gets so low, they decrease their estrogen production. Sometimes they become amenorrheic, so they don't even have periods, and so that puts you in a whole other category of risk for osteoporosis. Then medical conditions: rheumatoid arthritis, hypothyroidism, diabetes, lupus, renal failure. Those are some common ones. And this is it's kind of, you're damned if you do, you're damned if you don't. Drugs, steroids, which are used to treat rheumatoid arthritis. So you already got one strike against you if you got rheumatoid arthritis, and then one of the medications to treat it actually can perpetuate or make it a little bit worse. Hypothyroidism, you're using thyroid replacement for the hypothyroidism, but that in and of itself is another risk factor. And then Coumadin, a blood thinner, that actually can have an effect as well. So bone is constantly remodeling. Cells are breaking down bone and rebuilding bone. This is the natural course, the natural progression. And I don't know if, this may be the wrong analogy, but Thai fighters, the fighters from Thailand, they do a lot of kicks. And one of the things they'll do starting at a very early age is they take bamboo sticks and they hit themselves on the shins over and over and over again. And what it does is it causes micro fractures, but it remodels the bone because they're putting an outside stress onto their shin. So it's an extreme example of how you can actually modify your bone density, and then their shins become like steel. And so that's what it's exactly intended for. Now, that doesn't really apply to you guys, but unless you're going to pick up Thai fighting sometime soon. I wouldn't recommend it, however. I might be seeing a lot of you then. But the same can be said for any bones in the body. If you don't use it, you start losing it. And so inactivity will lead to progression of osteoporosis. So it's very important that you put those bones under stress and strain each day with whatever type of exercise you're able to do. So just to kind of, this was just going over some of the problems that are probably prevalent and relevant to you. But now, just how do we avoid injury? Number one, understand your baseline. And what I mean by that is, do you have osteoporosis? Do you have spinal stenosis? Do you have any types of limitations with your bones or joints that you need to be aware of before you embark on some sort of exercise program or trying to stay healthy? So getting an expert review, someone like myself, to kind of take a look at everything and say, okay, I don't want you doing kickboxing or Thai fighting. That would be a really funny conversation, by the way. But then posture. Posture is it's this thing that, you see, I knew that was going to happen. I knew that was going to happen. And I'm going to mention that about a dozen times hereafter, and every time I say it, everybody's going to do that. But posture, it's one of those things that nobody really thinks about, but it is constantly weighing on you. And it's weighing on you because of gravity. And I have a slide I'll show you in a minute that's going to illustrate that better than anything. Bending and lifting, that's another thing. We just don't think about it. And some people relate, I need to lift better as far as the way I lift, only to things that weigh a lot. It couldn't be further from the truth. It has nothing to do with the weight of what you're picking up. It has everything to do with how you pick it up. You could herniate a disc just by picking up your car keys. or a piece of paper or a brochure that fell on the ground, right? And so it's really not about how much weight you're picking up, it's about how you're picking it up. An exercise program. So after you've kind of figured some of these things out, then you can start getting on an exercise program that can put you on track to staying healthier and avoiding injury. Certain activity avoidance. If you're osteoporotic, wouldn't recommend horseback riding. Eventually something's going to fail, right? Once again, no Thai boxing. So drugs. There are many drugs out there that can be used to assist with all these different things that I've talked about, all these different types of injuries or conditions. Osteoporosis specifically, we have a number of different drugs on the market now that can actually help increase bone density. The only problem with that is it doesn't happen overnight. It takes about a year. It's a pretty long time. So you have to be taking any one of these drugs for about a year before we start to see any change in your bone density at all. And so you can take an anti-inflammatory and it'll take care of maybe your arthritis pain or your tendonitis pain, but for osteoporosis, you got to be much more committed. There's one of the best drugs on the market. I have no conflict of interest with this drug, by the way, Forteo. I prescribe a ton of it, but it's a once-a-day injection. Yeah, and unless you're diabetic, you're not used to doing that. So it's hard to convince people that have never had to do that to start doing that. But that is one of the most beneficial things you could do if you're already at a certain point as far as your osteoporosis goes. And so Forteo is a metabolic type of drug that completely, it's like an exogenous hormone. So the fact that you're no longer producing as much estrogen, you kind of get on maybe estrogen replacement as well, but then this works kind of like parathyroid hormone, which helps to increase bone density. But once again, it's a commitment, injecting yourself once a day. Now, it's not as bad as it might sound. It's almost like you got a click pin, just put it on your thigh and pop. And it gives a little micro dose, and it's a very small needle. So I would encourage anyone that has osteoporosis to at least consider that. Now, the future is looking bright with biologics as far as stem cells, platelet-rich protein, and then other types of proteins that we can use that are going to help build tendon, muscle, and bone. So understanding your baseline, as I said before, female postmenopausal, get a bone density. Know where you are. If you have enough risk factors, insurance companies must authorize it. Now that brings up a whole nother can of worms, is getting any of these studies authorized. It's very dependent on if I document things accurately. Because if I don't, they're going to kick it back and say, well, what are her risk factors? Well, I've gotten pretty good at playing their game, and so if you put the right words on the paper, we can get it done and we can get it pushed through, and then we can get a baseline of where you are. Thyroid, are you hyperthyroid, hypothyroid, are you taking thyroid, and how's that going to impact? A good medication analysis. Are any of the medications that you're on actually putting you at more risk? Because that's one of the things that you would submit to the insurance company, making sure that these were documented risks. And then any other medical conditions, as I said, like rheumatoid arthritis, etc. So hormone replacement, fall prevention. Like I said, any of these treatments for the first year, I mean, it's a build, right? So you still have to be careful during that first year, extremely careful, because you're still at increased risk of a fracture during that first year until we start getting the density rebuilt. And then age-appropriate activity. Once again, no full contact ice hockey or anything like that. So start with an expert review. Someone like myself. Figure out what you can and should be doing or should not be doing. And then what I like to encourage people to do, in this day and age, a lot of people have trainers. I'll go into that in a minute, but I prefer that someone starts out with someone that's a little bit more well-versed with pathology. You can know anatomy, you can know physiology, but if you don't understand pathology, the disease state, you can get into trouble. And so one thing that trainers are lacking is they don't have a full understanding of pathology. They don't understand spinal stenosis. They don't understand arthritic limitations of joints. And so they may be good rah-rah cheerleaders on the sidelines, but unless they truly understand what your personal limitations are, they may get you into trouble by saying, oh, come on, push through the pain. Let me tell you, if it's neuropathic pain from stenosis, you should not try to push through it. You need to let the pressure off, right? So I prefer that people start out with either a physical therapist or a chiropractor. Both of them are very knowledgeable as far as physiology, anatomy, and pathology. And then we do a diagnosis-specific kind of program thereafter. And then, if you really like your trainer and you want to get your trainer involved, or Pilates instructor involved, then have that person come in to a few of the sessions and learn. And they should always be open to learning. There it is again. Don't do this. We all do it. It's horrible. It's horrible. Every time you sit at the computer for more than 5 or 10 minutes, your head starts getting closer and closer to the screen. And it's reflexive. And one thing that I encourage people to do if you have a problem with something like this is get a digital timer. Keep it in the room with you, but put it across the room from you, all right? So when you sit down at your computer, kind of assess your posture, hold your head upright, but you have that digital timer on 15 minutes. And when that thing goes off, take note of what position you're in. I guarantee you're going to be like that. And so it's classical conditioning. We're just putting you in Skinner's box and just doing it again and again and again. And so you keep doing it until you start to feel the change as soon as your head goes forward. And then you're going to self-correct after a while. Now, this is a great illustration because it couldn't state it more clearly. For every inch forward that your head goes off axis, it's as if you're putting 10 more pounds of weight on your neck. That's a pretty impressive statistic. And so if you think about it, if you were to put, just even on your finger, if you were to put 10 pounds of weight down like that, it's pretty easy to support that. But the second I go off, it fades very quickly. Same amount of weight, you can't hold it up because all that stress and strain goes down the back side. So that's what's being transferred into your cervical musculature, right? And then on top of that, as you do this, you're going into further extension, although you're going chin forward, so it's as if you're putting more weight on your neck, so that's going to put more strain on the muscles and on the facets. You're also going into extension, which is actually closing down the neuroframe in the spinal canal. So if you even have a little bit of spinal stenosis, that position is going to make it worse. So spine biomechanics. We won't go into too much detail, but it's important that you understand it because this is what this all revolves around. You have vertical loading, right? The pressure coming from down, and then it hits the disc. The disc is supposed to work as a shock absorber, and when it's working effectively, it's very good. But when it starts to break down, then you start to get bulging out the sides. One of the things that can break it down is if you have abnormal loads on it over a long period of time with bad posture. So when you're constantly having that chin forward posture, you're constantly having that slouching position, you are loading those discs much more than what they should be, and you're doing it over long periods of time. I mean, there's many people that work an 8-hour desk job, and they're in these bad positions for most of the day. We were not designed for that. We were designed to run from predators that were chasing us, right? Not sit at a desk for 8 hours a day. And also, they're sitting at a desk and they're getting stressed out, and the whole cardiovascular side of things is, that's a whole nother thing. That is not a workout, by the way. Getting stressed out is not a good workout. So then here's another thing. Not only do we have the head and the chin posture or the neck posture, the lumbar posture as well. And so keeping that in a neutral spine position while you're seated is very important because the same biomechanics apply. The second you start to slouch, you increase the intradiscal pressure to one of the highest pressures it can possibly be. So imagine this scenario. You're sitting for 5, 6, 8 hours at a desk in this bad position. So that disc is preloaded throughout the whole day. Things are starting to fatigue. And then you drop your pen on the floor and you go boom, and you reach down really fast to pick it up. The disc herniates. You've already put it at a disadvantage throughout the entire day and for the past 3 years that you've been working that same job. Now you just blew it out because you didn't pay attention to how you bent down. So I had to throw this one in. Good posture is the first step to balance. And per Kristen Louboutin, when a woman puts a heel on, she has a different posture, a different attitude. She really stands up and has a consciousness of her own body. So, per Christian, you should all wear high heels all the time, and that'll keep you in a better posture. I'm not sure if that really works, but... So I'll move on to bending and lifting. So proper lifting technique, we talked about it a little bit, but it's really all about keeping balance, bringing whatever you're picking up close to your body and bringing it up your body, using your knees to bend down. Don't stoop and bend like this, right? Like over on the far right. There's also tripod lifting. This is a great technique where you just bend down like this, one knee, and you can pick whatever it is up. Even if it's 100 pounds, you can bring it close to you and then bring it up like that. Or if it's your keys, you just bring your and another thing is you can always brace yourself on a table or a chair to pick things up. Anything to kind of offload your torso is going to be helpful. This is not good either, picking up, and as the dog's running away from you. I can't imagine a worse possible scenario of things about to go awry. The dog's running away from you as you're trying to grab it and you're stretching and reaching, and it's only a 10-pound dog. Some would say that this is the best way to lift, have somebody else do it. And yeah, and in some cases, that's exactly what you should have happen. Of course, it's going to be kind of hard to have somebody pick up your keys every time. That'd be... So exercise, it improves your mood, reduces stress, makes you feel satisfied, improves self-esteem, improves body image, a sense of energy that you don't normally get. You usually get better sleep, improve confidence, confidence, and decreases depression. So you can also get injured doing exercise, and so these are the things to... This is horrible. I'm like telling you what not to do, but then also telling you to do something and you'll hurt yourself anyway. But no, as long as you're cognizant of it, as long as you know what things to be aware of as you're doing these things, once again, it's very manageable. But cardio, you can get tendonitis sometimes and bursitis. The ways to avoid this is to build up to it. Whatever you were doing 10 years ago, you're not going to be able to go out and do it 100% tomorrow. So you have to build back up to it. You have to go ahead and kind of train to get to the level that you want to get. So if you used to walk 5 miles 10 years ago, just start by going around the block once, honestly, and then slowly build up. And you'll get back to that 5 miles again, but don't try to do it right out of the gates because you're asking for trouble, specifically in the fashion of tendonitis or bursitis when you try to push too hard, too soon, too fast. Weightlifting, tendon ruptures, tendonitis, once again, tendon ruptures will usually only happen when you already have a tendonitis ongoing that's been kind of a chronic type of issue. Yoga. Yoga can be great, but for certain diagnoses, you have to just modify it and avoid certain types of poses. Hyperextension specifically for anybody that has a spinal condition. Pilates, certain types of Pilates moves as far as flexion. Swimming is one of the greatest things as long as you can swim. I guess... Yeah. Drowning is the biggest risk factor, I suppose. Yeah, I can just see that in the paper. Dr. Davis said no. Another thing, sport type of exercise. So tennis, golf, running, cycling. I put gardening in there because it's an activity. And I mean, if you're doing it long enough, you're working your forearms, you're bending down. And if you're not doing it correctly, it can really lead to neck and back problems. But with tennis and golf and running and cycling, once again, it's kind of building up to endurance, to levels of endurance. And if you go back to your younger days where maybe you were playing high school athletics or college athletics, you trained all the time. And somewhere in your late 20s and early 30s, it all kind of went away. We're no longer training, but we expect we can go out and play 18 holes and everything should be fine. You need to keep yourself in shape in order to actually tolerate those activities. All right, so you should sit this one out. The reason I say that is because when you're in yoga, you should sit this one out maybe. The cobra is, it really closes down the spinal canal, all right? And if you have any degree of facet arthritis or spinal stenosis, this will aggravate it. And I hate to see that when people are active and they're doing great, but then they try something a little new. And I mean, they could be cycling 20 miles a day and doing all sorts of stuff, and they go, oh yeah, I'm going to try yoga. They get in their class, they're healthy, they're active, they're athletic, and then they do this, and they're down for the count. And it's because it's a completely different movement for them. They haven't had any experience with it, and it's because there's a certain pathology lurking underneath that predisposes them to a problem in getting in this position. Maybe you should sit this one out too.
No intention.
Yeah, either one of those. Those are a little aggressive. Or you could have a psychological injury doing yoga next to this guy. So Pilates. I really do like Pilates because a lot of what Pilates is a neutral spine stabilization. But there are certain things that you can get into, certain positions you can get into, where if you have any kind of disc issues or things like this, or look, if this person had a neck issue, the amount of load that is going on to the cervical thoracic junction right there is huge. And so I would really have to clear somebody before they would even try that. Otherwise, what? You still trying to figure out what position she's in? Yeah, it does look like and maybe you should sit this one out too. So active stretching is good, but passive stretching can be bad. And the reason I put this up there, this is a very offensive picture, by the way, but the reason I put this up there is anybody that's been in a yoga class has had the yoga instructor go around and put his hands on your shoulder and, oh, stretch, breathe. And he has no idea what's going on in your body. He has no idea what you can and cannot tolerate. And so don't be afraid. Don't be afraid to tell this guy to get the hell away from you. You probably wouldn't be afraid, but usually it's not that extreme. But that passive stretching can sometimes be the thing that pushes you. I'm going to get that one off the screen now. But that passive stretching can sometimes be that thing that just pushes you over the edge. Now, this is an imminent fail, as you can see from the bottom. We're moving on to personal trainers now. And look, there can be some great personal trainers. And the best personal trainers are the ones that continually educate themselves. The best personal trainers are the ones that actually try to integrate themselves into your healthcare team. And just to let you know, the people that are sometimes giving you instruction, oftentimes they have a high school diploma. That's about it. They have on-the-job training. They may or may not have a certification. Some organizations now require a college degree, but that doesn't translate into understanding pathology. And I'll go back to that word pathology. They may understand anatomy. They may have done a lot of reading on anatomy and physiology, but that does not mean they understand what's going on in your body from a pathologic standpoint of, let's say, stenosis or arthritic joints. And so I've seen this in the gym. I've seen this all around where, somebody is signed up for this P90X type stuff, and I can't count the number of people I've seen get injured from that because they've been athletic, they've done certain exercises, but then they say, oh, I've heard people have lost a lot of weight and gotten in good shape doing this, but it's so aggressive, so fast, that it's just not a good idea. And sometimes I'll see trainers putting people in this weird contortion positions and then putting a weight in their hand, and I'm like, what in the hell is going on? And this is a classic example. Is who in their right mind would do that? It's bound to fail. But that's what happens. All right, so this is an actual story of a patient, Brenda, age 51. She had her first session with a trainer, and she was instructed to do jumping jacks while holding a medicine ball over her head. Anybody have any ideas of how that's going to end? Her hands got sweaty, the ball slipped out of her hand, landed on her head, and she got a compression fracture. Now, didn't get a spinal cord injury, but, once again, it's be smart. That's just not a good idea, and especially the first time out. There are these whole programs built around like medicine ball workouts and kettlebell workouts and things like that. And, you have to please always question who's giving you instruction, all right? Because they may not know more than you. You may know a lot more than they do, and you definitely know your body more than they do. And so if it starts to hurt, sit it out, right? If you're in that yoga class and you go, well, that kind of twinges, I'm going to back off on that one. I'll keep doing everything else, and if they come and try to push you, just, once again, tell them to back up. Don't be afraid to say no, because you're going to protect yourself more than that person is. So avoidance. If it hurts, don't do it. That is a very, very simple equation and a simple solution, at least for a little while, right? At least let us figure out what's going on, get it cooled off, then get you back in action. But taking a break from whatever activity it is that keeps on coming up is probably one of the best ideas you can do. I have a lot of runners that come in and they'll have plantar fasciitis and they go, every time I run, it hurts. Like, of course. And the most they do is like take a week off, and I'm like, this is a little bit of a longer process than that. But it's, modify that activity, whatever it is that is causing the problem, modify that activity. It doesn't mean you'll never be able to do it again. It just means that you have to really focus in on where the pain's coming from, what caused it. And the most common thing with those runners is these are people that are really used to running, like running marathons, half marathons, things like that. And what will inevitably happen is something will come up in life. They won't have run for 2 or 3 weeks, 4 weeks, and then boom, they go out and they try to run 15 miles. And then that's when it comes. That's exactly when it comes. And then once it comes, it sticks around. So medications can assist. I mean, I have a lot of people that are golfers, avid golfers and tennis players. And with, as I said, arthritic changes, chronic arthritis, sometimes it just is what it is. And if you have to take a Celebrex or an ibuprofen or an Advil preemptively before you go play your game, who cares? It's fine. There may not be a better answer than just prophylactically taking an anti-inflammatory before you go play. As long as you're not getting some sort of residual symptoms that drag on through the day, into the night, into the next day, then it's pretty self-limited. And starting with mild range of motion. When there is an injury, start back mildly and then train to play. Then just remember that, like I said, we used to train so much when we were younger for whatever athletic endeavor we wanted to do, and then somewhere in our late 20s and 30s we lost that. But it's time to get back into that. It's time to remember that if you do want to go out and play golf a couple times a week, you're going to have to do something else on top of that to keep yourself in shape. And so I went over a little bit as far as the drugs, the anti-inflammatories, topical anti-inflammatories, which are a great thing. This is really a beautiful type of solution, in my opinion, because a topical anti-inflammatory, you're basically able to take the GI system completely out of the equation. One of the biggest risk factors for any anti-inflammatories, oral anti-inflammatories, is GI risk, peptic ulcer disease, colitis, gastritis, any of those things in the GI tract, esophagitis, reflux. And when you have a tendonitis or an arthritis of a joint that doesn't have a whole lot of soft tissue around it, rather than put it in orally and have it go throughout your system and have it have its impact on the GI system and the kidneys, use a topical. You can use a topical. It's very local. It does much better, much more effective with lower doses right over the tendon, right over the joint. Hormone replacement, as we were talking about with osteoporosis, estrogen replacement, thyroid replacement, Forteo. Forteo is that one I talked about, the once-a-day injection, bisphosphonates. Bisphosphonates are an oral alternative, but they're not near as good as Forteo. And I'll go into a little bit of detail on that. Bisphosphonates, they increase your bone density, but the bone that it creates is not as resilient as natural bone, nor is it as resilient as the type of bone that Forteo builds. And the reason is you are replacing calcium with phosphate. And so it looks more dense when you do the scan. Actually, your numbers will end up looking better. But if you were to actually put that bone under stress and strain, it fails earlier than what normal natural bone does. Not that it's bad, it's a good alternative when you have osteoporosis if you can't handle the injection. So the future, biologics, cell transplants, whether it be autologous or allogenic. We're already doing some stuff with cells from bone marrow and also platelet-rich plasma. Platelets have a great deal of growth factors, and how that applies to these types of injuries. When you get a chronic type of injury, whether it be a bursitis, tendonitis, or arthritis, these things, all three of those types of tissues, the joints and the tendons, they don't have great blood flow. And in order to get good healing, you have to have good blood flow, right? So the problem is by design. We weren't designed with a great healing mechanism for our tendons and ligaments and joints. And so that's why we get these chronic degenerative changes, because they never get a chance to repair. But what we're doing now with cellular transplants and also platelet-rich plasma is we are artificially putting in concentrated doses of your own cells from your bone marrow plus your own platelets. Platelets are filled with growth factors. Those are the first things to go to any wound. When you cut your skin, platelets, that's what aggregates. That's what starts the whole healing cascade. So once the platelet degranulates, it releases about 13 different growth factors to stimulate the whole cascade thereafter. And now with adding your own cells into it, now it has a matrix to work with. So rather than just trying to tell the joint to start healing itself, you're actually throwing some cells in there for the platelets or the growth factors to tell the cells what to do, right? Now, a lot of that is still in study and still in test, but it's looking very, very promising. And we are able to do some of that stuff in the office already. Anabolic proteins, OP1, GDF5, fibrin sealant. There's a number of different growth proteins that are in the blood that have been isolated out. And I've been involved in a number of different trials where we've been injecting these things into the disc over the past 10 years. And so each one of them has shown a little bit more promise than the next, than the next, than the next. So we're slowly dialing in the science to where it won't be the fountain of youth, but what we will be able to do is to reference back to that disc degeneration transitioning to spondylosis. We'll be able to catch that disc earlier on, inject in growth proteins and cells, and get it to stop, to get it to basically stop it from progressing on to that next stage. This is just a little bit more about stem cells and what they can do. They can turn into a number of different types of tissues. That's where you get it. You get it from the bone marrow and the hip usually. The only problem with autologous stem cells, this is the only main problem, is that in a newborn, the stem cells in your bone marrow are about 1 in 10,000. Then as soon as you're a teen, it drops to about 1 in 100,000. At 30, 1 in 250,000. At 50, 1 in 400,000. And at 80, 1 in 2 million. So that's why we don't heal as well. That is the most simple graph telling you why we don't heal as well, because we don't have as many circulating stem cells in our system. So what we're going to see in the future is we're going to see banks, all right, cell banks, where you can donate your own marrow. It'll be grown out and cultured to where we can make this 1 in 400,000, and we'll turn it into a million, a few million. Then we'll be able to re-inject it back into whatever location we want to, right? Now the other thing will be is allogenic, because at some point, maybe at 80, even if we grow it out in culture, we can't expand it enough to ever be of benefit, because there's just not enough there. And once you split a cell line beyond 7 times, you open up to genetic mutations. And so you don't necessarily want to have a cell line that's been split out indefinitely, because you really don't know exactly how healthy those cells are going to be after about the 7th time of splitting. So for those types of individuals that we don't have enough cells, we're going to have allogenic cells. And those are going to be cells that are donated by young, healthy people that they'd have to pay a decent amount of money to get them. And they do already, because we're already studying them. But then you'll be able to get a packaged little vial of 6 million cells, 10 million cells. And so that's what we're working on right now. And so staying active and staying healthy, it's a chess match against time and age, right? It's a thoughtful approach. You have to know what your limitations are. Posture, everyone? Right, good, all right. Get a baseline assessment, know where you stand, get some professional guidance as far as how to deal with it, and drugs when necessary. It's not a bad thing. Tailored exercise program by people that know what they're doing. Activity avoidance. There's just, when you have certain diagnoses, there's going to be certain things that you just want to avoid. And then there's a lot of hope and promise in the future as far as cellular therapies. So thank you very much.